everyone, and welcome back to the journey. As you can see, today we're going to talk about the respiratory system, in particular, pneumonia. So let's just go ahead and get started. So, with pneumonia, it's an inflammation of the lung parenchyma that extends to the alveolar area that eventually is going to result in edema and exudation, which exudation is pretty much means sputum production, okay? Caused by various microorganisms, which can be because of viruses, bacteria, mycobacteria, fungi, parasites, right? All those different things. I put also is that when it comes to the viruses, those are pretty much mainly seen in your infants and your children. Okay, so when I get to the pediatric section, please check out for those videos so that way you can kind of get a better understanding of why you see more of those viruses within the respiratory tract system with the infants and children. All right. Also, you have your pathophysiology. With your pathophysiology, okay, I'll try to summarize it in a nutshell so that way you guys can get a clear understanding of exactly what's going on with a patient who has pneumonia. So they're exposed to the foreign matter, right? Whether it's the fungi, the bacteria, whatever it is, right? Gastric content. Then the body goes into an inflammatory response, right? So the lung starts to get inflamed. The capillary walls then begin to leak. When they do leak, the fluid shifts from the capillaries to the interstitial space. All right? From then, it also shifts from the alveoli. The alveoli then fill with the fluid. After it's filled with the fluid, the lung loses compliance, okay? And pretty much what happens is it's a VQ mismatch. And VQ just pretty much means ventilation, perfusion, mismatch, okay? And what that means is pretty much stating, right, there's a mismatch between the air that is passing through the lungs and the blood supply that also passes through the lungs, okay? So the blood supply and the air supply is a mismatch, all right? That is the big thing that I want you guys to get when it comes to VQ mismatch, okay? That's pretty much what it's saying. So low ventilation, high perfusion shunt, the blood bypasses the alveoli without the gas exchange, right? So there's no gas exchange. The gas or the air supply, right, exchange is not adequate enough with the blood supply exchange, all right? And then you have your classification, which you have different types of pneumonia, all right? You have your community-acquired pneumonia, hospital-acquired pneumonia, aspiration pneumonia, and ventilation-acquired pneumonia, okay? They also had in the book, in the Bronchopneumonia book, immunocompromised pneumonia, but again, immunocompromised pneumonia, anyone who has a low immune system is going to be able to catch not just only pneumonia, but many different diseases or sicknesses out there just because you have a low immune system to fight off any infection. So I didn't want to add that one there just because it's not something that you see on questions a lot. These are the main four that you will mostly see. But, you know, just for those of you guys who like that extra information, yes, immunocompromised pneumonia is also another classification, okay? But I won't mention it as much. I'll mention it here and there, but not a specific topic on its own, okay? Just because anyone who has immunocompromised is going to be more prone to having a lot more diseases. We're going to go over the classification. Why? Because these are some test questions that they love to ask, the difference between community-acquired pneumonia versus ventilation-acquired pneumonia versus hospital-acquired pneumonia, okay? So I just want to go over the key points that you need to watch out for to know the difference between each one, okay? So you have CAP, which is obviously in a community setting, right? Which community setting meaning my home, school, wherever. Pretty much anywhere except a hospital, all right, is your community setting. And this happens within the first 48 hours after hospitalization, okay? And the causative agents, you have S. pneumoniae, H. influenza, Legionella, Pseudomonas aeruginosa, okay? Those you don't need to know as far as the causative agents. That's just there just for extra information, just for those of you guys who would like to know what kind of bacteria you would see, all right? That doesn't mean that it's not limited to other ones, but these are the more common ones that you will see with the community-acquired pneumonia, all right? It occurs mostly in 65 years of age and older adults, and it can be because of a lack of the flu shot or the pneumococcal vaccine, all right? So a lot of times when you start working in a hospital setting, two of the main vaccines that you have to check off on or sign off on to make sure that the patient wants them or they refuse is the flu and the pneumococcal. So they'll fill out a sheet of paper if they would like to take the flu or the pneumococcal, or if they want to refuse it, then they can also put that in as well. And they will get these shots after discharge, on discharge, okay, of the hospital stay. Also, a history of alcohol use or tobacco use, all right? So ETOH is acronym for alcohol. So you have your HAP, which is also known as pneumoscomial pneumonia. All right, so anytime you hear the word pneumoscomial or hospital, we're talking about the same thing. All right. Also, the onset of pneumonia symptoms are more than the 48 hours after admission. All right, so big difference. This is within the first 48 hours after hospitalization, right? So they have to wait a complete 2 days, right, for them to develop pneumonia, for them to then decide that, hey, this did not happen because of the hospital, because 2 days after, this is when you got the pneumonia, okay? Whereas hospital is 48 hours after admission. So once you got into the hospital, 2 days after you arrive at the hospital, you have pneumonia, all right? So those are the two big differences with community versus hospital. They love to ask those questions, so again, try to remember those things. They both happen in a 48-hour time period. One is after hospitalization, one is on admission, all right? Also, these are some of your causative agents. You have Enterobacter, E. coli, H. influenza, which is the same as this one here. You have your MRSA, and you also have Calbacella, okay? Also, one thing you need to know is that it can be caused because of prolonged hospitalization, hypertension, coma, aspiration, comorbid conditions, which is pretty much your patients who mainly have COPD, alcohol use, or DM, which is your diabetes mellitus, okay? So patients who tend to have these background history or pathological history or still have those conditions are more prone to contracting hospital-acquired pneumonia, okay? Hospital equipment, right? Sometimes it could just be the hospital equipment or the machines or your respiratory treatment or therapy. So those patients who have to go under respiratory treatments where they get the dual neb, or they have the mask, or they have the one that goes in your mouth, and they're getting the albuterol and things like that, they're more prone to catching pneumonia because what happens to that equipment? It gets put on the bedside, or it gets put, somewhere, because you want to make sure that you kind of limit the cost and use one per person, so you're not going to continually get a new mask each and every time. When you go home, you don't have a new mask every time. So with that said, you want to make sure that you're cleaning the equipment and that it's in a sterile environment and away from different bacteria to getting on top of it, because eventually, if it's contaminated and you're putting it in your mouth and you're getting your treatment, those bacteria also flow into the lungs as well and can cause the pneumonia. All right. Same thing for the hospital equipment, right? Things on the bedside, or just a failure of the good cleanliness. Okay, of cleaning the room before, and the person is in the room, they're in the bed, and they're touching the side rail, they're touching the call button and things like that. And they may put their hands in their mouth, or different things. Next thing you know, they have a hospital acquired pneumonia. Okay. Another thing is poor nutrition. Okay, so a person who has poor nutrition is always going to be prone for catching different diseases, because your body is not able to get the nutrients that it needs to function in the order that it needs to function. Okay, and another big thing to kind of prevent all of this from happening in the hospital is pretty much proper PEE, which is pretty much your putting on your gowns, your gloves, your mask, your eye shield, whatever it is that you may need for that task at that particular moment. You want to make sure that you properly handle yourself with them on and properly take them off. Okay, so it's one thing to don them on, another thing to take them off. Okay, so that is a big thing that can help prevent. And of course, hand washing of the hands. Okay, or using the hand sanitizer. VAP, right, is considered as a type of pneumoscomial pneumonia. So this is pretty much something that can occur in the hospital. All right. So this is almost in the same category, pretty much in the same category, but it stands on its own, all right? So with that said, it's an endotracheal intubation or mechanical ventilation that occurs when a patient has acute respiratory failure, and this happens for at least 48 hours, okay? So again, each of them have 48, 48, 48 hours. So you just need to know the difference between the two. So this happens 48 hours once they've been on the mechanical ventilation, all right? And one thing that the hospital requires to prevent that from happening is pretty much a vent bundle. And when you go into the hospital setting, especially if you're on an ICU floor or a step-down ICU, okay, you're going to see oral care. And the oral care agent that you're going to see, the solution is chlorhexidine, okay? Those are going to be the oral solutions that you use to swab the patient's mouth, to make sure that you clean the patient's mouth, that you suction them, you know, when needed, those things, okay? Also, you want to keep the head of the bed 30 to 45 degrees, because remember, when you're on the vent, a lot of times we take for granted that, you know, when we're breathing on our own, we're able to clear out our lungs, right? We're able to take a deep breath. We're able to cough, right? When these people are ventilated and they're on sedation medication, they're not able to do those things. So all of those secretions build up and stay within the lungs, right? And that's why you have to suction and get those things out. So it's like the nurse is being their lungs, their coughing mechanism, right? Because they're not able to cough. Some may not be able to cough or may not be able to cough effectively to be able to produce a good enough exudate to come out, okay? So those things get trapped on the inside, and of course bacteria love warm, dark, cool, moist places, all right? And that creates the perfect environment. So you want to keep them 30 to 45 degrees up so that secretion is not sitting there, right? But gravity is able to help with that, all right? And hand washing. Hand washing is always going to be a big thing to help prevent different bacterial growth from occurring, all right? And then, like I told you before, you have the immunocompromised patient. So I will talk about it, mention it, but again, immunocompromised patient can be prone to just about anything, all right? And pretty much what puts a patient into a category of immunocompromised is pretty much the use of corticosteroids, immunosuppressive medication, right? If they had a kidney transplant or any type of transplant, they're now going to be on immunosuppressive medication because you don't want the immune system to now attack that new organ, all right? Chemotherapy patients, people who have AIDS, and then you also have your immune disorders like people who have lupus or those sort of things, all right? So that puts you in the category of immunocompromised, all right? So again, this is the other category that a patient can fall under when it comes to pneumonia, is an immunocompromised patient. All right, and last but not least, with classification, you have your AP, which is your aspiration pneumonia, and with that, it's pretty much pneumonia from entry of endogenous or exogenous substances into the lower airway, okay? So pretty much, don't get caught off guard by hearing the word exogenous or endogenous. Endo means inside the body, exo means outside, right? So these are just pretty much substances that can be found inside or outside. So of course, inside you have your gastric contents, right? And then outside you have either food, drinks, right? Chemical irritants, irritating gases, things like that that can come from the outside going in. And then endo is anything from the inside going into the lungs, right? In places where it's not supposed to be. So your examples like I have here, gastric contents, food, chemical contents, and irritating gases, okay? And then you have your bacterial infections, which are your most common form, right? And then you have your S. pneumoniae, H. influenza, and S. aureus, okay? So like I said before, it's okay if you don't know the different bacterial agents. You're not really going to be tested on things like that. But those of you guys who would like to know that information, it's stated here for you, right? And it's not limited to other infections. These are just, again, the most common, all right? Finally, our clinical manifestations, right, which is also known as our signs and symptoms, which is also known as our nursing assessment. So what are we going to assess as a nurse? What are we going to see for the patient with pneumonia? They may have chills, increased temperature, and temperature meaning from 35.5 to 40.5 Celsius, which in turn is 101 degrees to 105 degrees Fahrenheit. You'll also have your pleuritic pain, chest pains that you're going to have, right, because of either deep breathing or coughing. You also have tachypnea, which tachypnea means an increase in respiratory rate, and that is a rate of 25 to 45 breaths per minute. Also, you have your adventitious breath sounds. And remember when we did your, when you have your respiratory system or your lung assessment, right? You listen for those breath sounds to see, is it normal? Is it rales? Is it bronchi? Is it wheezing? Or is it diminished breath sound? Okay, so those are what you are going to auscultate to try to hear or see or assess for a patient who has pneumonia. All right. Next, you have the use of accessory muscles, and accessory muscles are your muscles here in this region, right? In these regions as well. And again, anytime you see someone have to breathe and you see those respiratory muscles, those accessory muscles being used, that lets you know that they are in respiratory distress or have some type of shortness of breath. So again, you should not be using your accessory muscles and a normal person who breathes normally, right? But if you are having shortness of breath, you will see that. So that is a sign to let someone know, hey, maybe they have a respiratory condition known as pneumonia. All right? Also, you may see mental status changes because again, what is going on? There is a failure of gas exchanges, right? Oxygen going to the brain. So anytime that is going to happen, you are going to see mental status changes, all right? And then your sputum production. Your sputum production, you're going to have more of a sputum production, and it's going to have a rust-colored tint to it, okay? Some may have a rust-colored tint to it. Our clinical manifestations, continuation, all right? So you're going to have your tachycardia, which is going to be seen more on your bacterial infections, and then you have bradycardia, which you will see more on your viral infections, okay? So it doesn't mean just because you see someone with tachycardia or bradycardia means something that's not right. It can just kind of give you an idea that, hey, they just have two different types of infections, okay? So keep that in mind. Also, you have your nasal congestion, right? And you have your sore throat, which is your pharyngitis. You also have headache, poor appetite, okay? One thing I want you guys to remember, with almost every respiratory problem or disorder or disease that you may have, poor appetite is going to be one of the signs and symptoms that you are going to see. Because think about it, if you have the options to breathe or to eat, most people are going to breathe rather than eat, right? So again, it's almost like you remember your ABCs, right? Airway, breathing, and circulation, right? Before I decide to eat, I want to make sure that I have an airway, because at the end of the day, what good is it if I eat and I'm out of breath, right? And I pass out and you know, I'm down on the table, or I have a chance to live by breathing in more air and trying to breathe harder or whatever the case may be, right? Most people are going to breathe overeating, all right? So just keep that in mind when it comes to respiratory failure or respiratory problems or things like that. Most of the time, you are going to see poor appetite, or they have not eaten at all, okay? Also, the cheeks may be flushed. Lips and nails are going to be cyanotic, okay? So I put cyanotic in blue because I let you know it is going to be blue, right? If you are deprived of oxygen, that nice pink color that you have is no longer going to be nice and pink. They are going to be blue, all right? And that is going to happen when you have your severe pneumonia, all right? Also, you have arthropnea, and pretty much arthropnea means difficulty breathing when positioned, okay? So when you're positioned flat, right, and all of a sudden you have difficulty breathing and you need pillows to prop you up, that is arthropnea, okay? Also, if you guys remember, when you have your respiratory assessment, right, you had some tests that you had to do to make sure that the patient status was normal, and you have your egophony test, you had your whisper test, right, and then you had your tactile firmness test, where pretty much you put your hand on their back and you tell them to repeat 99, and you go and you listen or you feel for the vibrations, right? So with those things here, with your egophony, right, the E is going to sound like an A. So with egophony is when you tell the patient say E, and you go to those different places with your stethoscope and listen for that E sound. Well, for a patient who has pneumonia, that E sounds like an A. For your whisper test, remember, you have them face that way, right, and you're listening to their back, and you have them whisper 1, 2, 3, right? So it's 1, 2, 3, and you're not supposed to hear, right? In a normal person, you're not supposed to hear. But with the person who has pneumonia, you now all of a sudden hear 1, 2, 3, 1, 2, 3, right? And the reason for that is because sound is better heard through solid than through air. Okay, so that lets you know that there's fluid or some kind of consolidation within the lungs that is going on or that is taking place. Also, you're going to have an increase in your tactile firmness, right? You're going to have more vibrations. So when you put your hands on their back, right, and you're listening to the different parts of the lobe, right, you're going to feel more of a vibration. So we have diagnostic testing. So with your diagnostic testing, these are the things that you want to look out for, okay? You have your physical examination, which is your respiratory assessment, right? When you go ahead and you percuss, you also take, all right, you inspect, you make sure that the chest rises and falls evenly, that there's not the use of the accessory muscle. All those things can let you know that something is going on with the respiratory tract. So you want to make sure that you are, doing your physical examination. Also, you have a history of respiratory tract infection. So where do you get your history from? From your patient. As long as they're AO times 3 awake, alert, and oriented, right? And they're able to speak appropriately and be able to answer the questions and they're able to follow commands and it's clear for their mental status, then you can go ahead and ask questions about the patient. Have you ever had a respiratory tract infection before? And find out, are they a tobacco use smoker or do they use alcohol? What are some comorbid disorders that may contribute to pneumonia or things like that. So, of course, your patient is also your best guide in knowing information about the patient because who knows yourself better than you, right? Also, you can do your chest x-ray, right? And with your chest x-ray, what you're going to see on a chest x-ray to let you know that something is going on, right? You may see a lobar or segmental consolidation, pulmonary infiltrates, or pulmonary infusions, right? All those things you will see on the chest x-ray. And you will see the different colors. Most of the time, the x-ray is 3 different colors, right? You have white, you have gray, and you have your black, all right? So when the doctors go ahead and look, there may be some areas that are just completely white out, right? Some areas that are completely dark. So again, those are going to let you know exactly what's going on. Also, your blood cultures. So your blood cultures is pretty much used to see if there's a bloodstream invasion, right? If that bacteria has not invaded into the bloodstream. You also want to do sputum cultures because your sputum culture is what's going to identify the organism in itself, all right? And then you have your labs. And with your labs, you're going to see an elevated white blood cell count and erythrocyte sedimentation rate, all right? So those are the things that you're going to should expect on your labs to see. Also, with the blood cultures and sputum cultures, they can take time to come back with the results. So in the meantime, while this patient is having the infection, you want to make sure that you give antibiotics within 4 hours of the treatment time, okay? So as soon as they get in for admission, they do the chest x-ray, you find out that they have pneumonia, you want to be able to give them antibiotics within 4 hours. So what you do, you give them a broad spectrum antibiotic, which is pretty much antibiotics that works for a big group of bacteria. And once you find out what the sputum culture is, and you are able to identify that organism, then you're going to use that specific antibiotics for that specific organism to make sure that you kill that organism, okay? So that way it prevents you from having resistance to other types of infection just because you're using a broad spectrum that can kill just about almost anything, but you want to make sure that you're killing that specific organism with the less amount of antibiotics as possible, because again, bacteria do build resistance, okay? So that's just information I wanted to state about the sputum culture. Alright, so the complications of pneumonia. Alright, so we have hypertension and shock. We can also have respiratory failure, especially, right, if we have gram-negative bacteria. For some reason, those cause the most damage when it comes to respiratory. Also, the reason why you may have complications in the first place is because the patient may be resistant to the therapy, right? Bacterial or some type of resistance, a delay in treatment, or the fact that they have had no treatment whatsoever, all right? So, of course, if you don't treat something, there's always a risk of it getting worse and causing more complications, all right? And some of the major complications that you will see are pretty much your cardiac complications, which you have heart failure, cardiac dysrhythmia, pericarditis, and myocarditis. So now we're on to the medical management of pneumonia. All right, so I did my best to try to color code different types of antibiotics, so that way you can kind of, it can jump out at you and you can see it a lot better. So again, the antibiotics is going to be based on the gram staining, right? Which is pretty much when you do your sputum culture, whatever the organism is identified of, then that's the antibiotic that you're going to use for that bacteria, okay, or that organism. So if a patient has no risk factors of any drug-resistant type of pneumonia, right, they're going to use your categories of your microlids. And drugs in those categories is your erythromycin, clarithromycin, and then you have your erythromycin. Okay, so if you notice, they all end in mycin. All right. Then you have your outpatients with community-acquired pneumonia with cardiopulmonary diseases, and you're going to use your fluoroquinone, which you have moxifloxacin, you have gemafloxacin, then you have your levofloxacin, which is also known as your Levaquin, okay? Or you can use, this is a different category, right? Your beta lactamin agent, which you have your cefepime and your cefuroximide, plus a macrolide, which these are your macrolids up here, okay? So I try to keep all the macrolids as blue, right? The fluoroquinone as purple, and so on and so forth, okay? Now, when it comes to these antibiotics, don't stress yourself out if you can't remember which antibiotic is going to go for which thing, okay? The main thing that I want you guys to understand is that if you have a bacterial infection for your pneumonia, that you're going to treat it with antibiotics, okay? That is the main thing I want you guys to get. You don't have to, you know, bombard your head with trying to memorize all these antibiotics. If you can, great. If not, it's okay, all right? The main thing we want you to get is you're going to give antibiotics, because at the end of the day, we don't prescribe any medications or so, the doctors will, okay? And you will have a ID doctor on the case, which is pretty much an infectious disease doctor, which is a doctor who deals with all kinds of different infections, and he will be the one to prescribe a different medication based on the different types of organism that is seen on the culture, okay? So our biggest thing is pretty much to, you know, follow through with treatment, so that way there is no resistance, and watch out for signs and symptoms of the medication, and, you know, be prepared to act accordingly if there is an adverse reaction to one of these medications, okay? And then just pretty much teaching the patient about compliance and things like that, all right? So this is just extra information. The main thing I want you guys to get is that you're going to treat with antibiotics for bacterial infection. All right, so I'm just going to go ahead and continue. So stable is pretty much a temperature of 37.8 degrees Celsius, which is 100 degrees Fahrenheit or less, okay? And most of the time in the hospitals, they don't treat a fever until it's 100, over 100. So 100.3 or 101 or so, that's when you start to treat a fever. Other than that, they'll kind of just let you sweat it out on your own. You can give ice packs or so, or just take off the covers in the meantime, okay? So that is considered stable. A respiratory of 24 or less, a heart rate of 100 or less, and O2 saturation of 90 or above, and a systolic blood pressure of 90 or above, okay? Those are all considered stable in a patient who has pneumonia, because again, they were once higher than that, so we're seeing that, okay, this patient is responding to the medication, all right? Also, if the patient has a drug-resistant organism, right, maybe sometimes they can use a 3 antibiotic combination drug therapy that can be used, and what they will use is you have your anti-pseudomonial, which is your cephalosporin or your ceftazidime, or your anti-pseudomonal carbamazepine, or your Zosyn, okay? A lot of times I've used Zosyn quite frequently. It's a drug that most of the time it's in our ICU unit. The other name is piperacillin, and I've seen that medication multiple times, given multiple times. So that is a drug to get familiar with if you start working in the ICU, just because that is a medication, antibiotic of choice that a lot of doctors would like to use, okay? Also, you can use fluoroquinone, which I put in purple because these are your categories in that medication. You have your aminoglycoside, and then you also have your linezolid, and then you have Vanco, eventually, if you get to that point where you need it. all right? And you want to assess all of these things within 72 hours, which is your 3-day span, to make sure that they're getting their treatments and that they're responding to the medication, all right? And then I put an asterisk here to kind of remember when you have a viral infection. So if your pneumonia is because of a viral infection, you are not going to get any antibiotics whatsoever. Antibiotics only works for bacteria and bacteria only, okay? It will do no good to a person who has viral infection, okay? It would not help it at all, okay? Antibiotics is for bacteria. Think of the B in biotics for B for bacteria, all right? That always helped me. And the only time you will use it if your patient has viral infection if the secondary is a bacterial pneumonia, okay? So only if you have both a viral and a bacterial, and that's causing the pneumonia. Of course, I'm going to give you the antibiotics to treat the bacteria part, but I'm not going to give you any antibiotic if it's just only viral only, all right? So just remember that. All right, and last but not least, our nurse interventions. So again, you want to administer oxygen, and you want to monitor the O2 saturation, make sure that it's 90% and above. You also want to monitor respiratory status, right? Are they having labor breathing? Is this do they look cyanosis? Do they have cold, clammy skin, right? Those are things you want to monitor for. Encourage coughing and deep breathing and the use of incentive spirometer. So again, when you're teaching a patient how to use the incentive spirometer, remember you want to let them know, think of incentive as in, so you want to breathe in, right? You breathe in, you have a marker, a blue marker of a goal rate of where you want the patient to be, whether it could be 1,000, 1,500, 2,000, whatever they're able to do, and it's an exercise to help strengthen the lungs. So you may tell them to do it 10 times every hour, okay, until they go to bed. All right. You also you want to place them in semi-phallus position, which pretty much improves breathing and lung expansion. All right. You also want to change their position frequently, okay, so that way you can kind of move those secretions that's kind of they're just sticking to each other. You want to move them, okay, so that way it loosens up the secretion, so that way when they cough, they're able to spit all of that out, okay. So another thing you have is your CPT, which is your chest physiotherapy, and what that is pretty much physical therapy will come around and pretty much almost beat their backs like a drum, and what that does is loosen up the secretion. They also have on the ICU beds at my job, the beds itself, they have a setting where you can just go ahead and put CPT, and the bed itself starts to vibrate and move as if the respiratory is beating on their back like a drum, okay? And what that does is, again, loosens up the secretions, okay? Also, you want to provide suctioning. You can do the nasotracheal suctioning, right? Suctioning within their mouth. If they have a vent, you want to make sure that you're suctioning the vent, so that way they're able to get all that secretions out of them. Okay. Also, you want to monitor the color, the consistency, and the amount of sputum. All right. Because if it's yellow or that brownish color, that lets you know that the patient does have an infection. All right. And you may want to take that for culture, so that way they can know exactly what's going on. Okay. Or change in color. All right. So it can start off as yellow, and then it works with being clear. Clear secretions are good secretions, okay? You want it to be clear. Also, you want to provide an increased calorie, increased protein diet with small, frequent meals. And again, you don't want to give them big meals because they're going to have an overexertion and they may have shortness of breath. So you want to give them short, small meals that they can have frequently throughout the day, so that way they're still getting the calories that they need, okay? Also, you want to provide fluids, okay, and this is mainly for the people who have viral infection, okay. So again, like I told you, the viral infections, you're not going to give antibiotics. Instead, what you're going to do is give lots of fluid, because this patient may be dehydrated. So you give lots of fluids and rest. Most of the time, for any viral infection, the antidote is always going to be rest and fluids, all right, lots and lots of fluids. So again, the fluids is all based on what the patient is able to tolerate, because if they have congestive heart failure on top of having the pneumonia, right, there's only a certain amount of fluid that your body is able to handle, right? So yes, they may recommend 3 liters a day to help thin out those secretions and help them moving around and things like that. But if it is contraindicated, then you're going to do per doctor's order, Okay, maybe 1 liter instead of 3, or you know, very, very little. Okay, so it all depends. Next you have is you want to provide rest. Like I was saying before, you want to provide rest and increase activities gradually. Not suddenly, but gradually, because again, all that physical exertion can cause shortness of breath and cause respiratory distress. Antibiotics, which I stated all the different types of antibiotics that you could use. And then you have your antipyretics, which antipyretics pretty much are your medication that helps with decreasing your temperature. Alright, and one of the best medications for that is your Tylenol. Okay, so Tylenol is in the category of an antipyretic. Also, you have your bronchodilators that helps to dilate, right? Your bronchioles helps to make sure that you're able to pass more air through, okay, especially if you have bronchoconstriction. You also have your cough suppressants, your mucolytic agents, right, to help decrease the mucus, and then your expectorants, okay, which is pretty much your expirations, your secretions. Another thing, and I put that in an asterisk, is your nasal decongestion rebound. So sometimes the patient may have nasal decongestion medication, but if you take too much of your nasal congestion medication, what it can cause is a nasal rebound, congestion rebound. Okay, so you can be more stuffy than when you started. Okay, so again, you just want to make sure that they're monitoring the intake of how much nasal decongestion medication that they are taking. Okay, and that's a question that they love to ask about the nasal rebound. Okay, so just remember those little hints here and there to let you guys know what to expect when you have to take the test. Okay, also hand washing, hand washing, hand washing. Okay, most of the time, right? Anytime you have a question and the answer within the answer choices is hand washing, 10 times out of 10 times it's hand washing, okay? So hand washing and proper PPE, putting on of the equipment, and then the disposal of the equipment, alright? And then last but not least, your teaching. So you want to make sure that you teach the patient everything that there is to know about pneumonia, right? About their vaccines, the flu vaccines or the pneumococcal vaccine, notifying the healthcare providers of their signs and symptoms, or if they're taking medication, the signs and symptoms of the medication. You want to let them know that they should have adequate rest, proper nutrition, prevention of exposures, right? So if you've had this before, you want to make sure that you're not putting yourself in exposure to another individual who does have this, right? Because then if you're immunocompromised or so, you're more prone to getting it again, all right? So you want to make sure that you limit your exposure to, different bacteria and different things that are going to cause you to get the pneumonia, all right? And that is pretty much it. Pneumonia. So thank you for watching. If you like this video, please give it a thumbs up. If you have any questions or comments that you would like to just mention, go ahead and put that in the comment section below. Again, remember to check out my description box for more added information. And if you have not subscribed already, what are you waiting for? Go ahead and click that subscribe button. And again, thank you for watching and coming on this journey. See you on the next one.